Now we will turn our attention to a few central medical science foundations upon which the new paradigm has been created. In 2001, the nonprofit Health Education and Research Center was formed to investigate why the hearing aid adoption rate or acceptance was so low and what, if anything, could be done to improve services to your patients. Its mission was defined by three main objectives. The HEAR Center's original hypothesis emerged after a review of how the dispensing profession achieved its primary goal, which we've already mentioned, was to improve audibility with hearing aids to compensate for the loss of natural sensitivity to sound. The HEAR Center took a paradigm-shifting approach. We concluded at the outset that the only legitimate healthcare objective had to lead the patient toward recovering natural language skills and, as a result, restoring as much fluent comprehension as possible. From our perspective, recovery could only be reached by expanding professional protocols to include case management, scientifically grounded amplification protocols, and possibly extraordinary therapies. We postulated that an ideal, personally tailored treatment plan would need to become the framework from which a solution could emerge. And if so, it would have to be underpinned by much more salient factors than simply the results of an audiogram. So HEAR committed to replacing a primitive goal with a medically valid one. Once literature reviews and outcome studies were completed, HEAR identified a major constraint, which called for confining our treatment steps so that they would fall within cognitive load theoretical guidelines. This theory was identified by Doctors Chandler and Sweller. Applications were developed by numerous experts. Once we established our primary goals, we identified a list of medically valid criteria and principles. Medical literature revealed numerous molecular participants which only functioned as a result of extraordinary stimuli. Our goal was to develop amplification and therapeutic steps which could trigger the thresholds necessary to potentiate those functions. What we had in our favor was 24 years of outcome reports and a primitive model upon which to build. Our first step involved identifying any molecular substances that could limit potentiation or otherwise play a role as antagonist or treatment mediator. This opened the door to an entirely new category of potential toxins. Some of these compounds were simple ions, such as calcium or magnesium. Others were far more complex enzymes and neurotransmitters, such as calcium calmodulin kinase 2 and glutamate. We also realized that a variety of medications were already known to act as calcium channel blockers and inhibitors of both neurotransmitters and enzymes and any other number of substances. These novel parameters established the boundaries within which amplification and treatment steps would be constrained. Neurotransmitter receptors, enzymes, cell signaling molecules in the glial domain, proteins critical to long-term potentiation, vesicular trafficking, protein production, myelin plasticity, and synaptogenesis dynamics are examples of the functions which helped establish valid steps. Even though digital signal processing technology remains very limited, we were able to rely on indirect metrics to determine the likelihood that this emerging procedure of retraining and recovery was in fact engaging the natural processes to the degree that the molecular circuitry was leading to restored fluent comprehension. Throughout the trial, patients and their companions recorded their observations faithfully. They played a key role in our ability to track their progress in the non-rehabilitative settings. This allowed us to record the complications they faced as they progressed through to a reorientation of a healthier balance between the language schemas. What became obvious during the trials was that the key to successful treatment would not only depend on the recovery of the dynamic range of hearing, but also on how effectively the patient complied with the therapeutics and committed to progressively reorienting those schemas. This was manifested in progressive stages throughout the experimental open-ended treatment regimen. Sensory gating is the ability to direct one's focus on a priority stimulus and filter out competing stimuli. Attentional biasing is the ability to focus, sustain, select, alternate, or divide one's attention between one or more competitive auditory signals. Each of these acquired skills becomes progressively difficult for an individual presenting all but the simplest of signs and symptoms of common hearing loss. So in addition to the objectives previously mentioned, we concluded that medically based treatment must also focus on recovering these two primary skills. Developed in infancy, these two cognitive functions deteriorate as hearing loss progresses. The conditions which allow them to be developed and automated in infancy must be replicated in the adult in order for recovery of language skills to become optimal. This necessitated the development of treatment steps which would prompt the patient to gradually recover all 5 levels of attentional skills as identified by Drs. Solberg and Mateer. Their groundbreaking research offers significant insight into how cognitive rehabilitation can be improved in treatment for sensory neural hearing loss. As we delved into cognitive rehabilitation, we began to realize how precise and how complex auditory stimuli must be in the rehabilitative setting. We also realized that any amplification and therapeutic steps that we could develop would only serve the patient properly if those steps did not attempt to replace the natural language processing skills with so-called advanced features of hearing aids. Soon after digital hearing aids were developed, it became increasingly challenging for manufacturers to distinguish their hearing aids from their competitors. Every one of the top 6 global hearing aid manufacturers created multiple algorithms designed to counter or address the hearing aid user's main concerns. These algorithms creatively altered the intrinsic characteristics of auditory signals in various ways so the hearing aid users could hopefully report more improvement in their hearing aids than in a competitor's hearing aid. We all measure whether the flow of comprehension is being obstructed by whether we are able to keep up with the flow of conversations as they are going along. So as outcome reports became available to hearing aid manufacturers, they competitively engaged in a digital signal modulation race to create advanced features designed to overcome those obstacles. This prompted us to investigate whether the manipulation of auditory patterns were actually becoming inconsistent with the intrinsic natural auditory patterns that the individual's molecular circuitry was based on during language development. We concluded that the likelihood that all 6 manufacturers were separately confining their algorithms to ensure that they were consistent with the natural characteristics of auditory patterns defied any conceivable odds. Such constraints have never been reported in medical research or supported by ancillary research. As a consequence, we concluded that the individual's intrinsic auditory patterns could well be significantly altered by digital modulation before entering the auditory neural domain. This suggested that the amplified signals are highly likely to be transmitting an array of auditory patterns far more likely not to be synchronized with natural patterns and thus not capable of triggering highly desirable restorative neurobiological interactions. In artificial intelligence, when creative programming fails to synchronize with original programming language and is attempted to be integrated into artificial intelligence circuits, it is classified as heresy and removed just as soon as it is discovered. We found this to be the most likely consequence of unrestrained alteration of the dynamic range by manufacturing algorithms. We characterize this methodology as providing a primitive digital crutch which almost certainly would prevent a high level of recovery of natural language functions. This approach spilled over into applied natural language skills which the hearing aid manufacturer attempted to modulate. That includes the natural capability to increase the ratio of desirable sensory signals relative to background noise, which is known in the industry as signal-to-noise ratio enhancement. It also applies to natural gain control mechanisms and artificial noise reduction capabilities. Each of these issues became major concerns. The only mechanism that was determined to be constructive in the manufacturer's creative amplification models was wide dynamic range compression. As a result, we deactivated all creative advanced features in the trial. The HEAR Center identified independent variables typically considered in developing treatment plans for cognitive, behavioral, and neurological conditions. Only one valid dependent variable was plausibly identified for hearing loss, that being, of course, fluent comprehension. Once each main independent variable was identified, it was integrated into an expanding multivariate trial. As the factors and medical mediators were identified, their relative impacts on the recovery of fluent comprehension were incorporated into a dynamic calculation algorithm which systematically altered amplification and verbal therapeutic regimens. Interim results were attained. Over the long term, the average improvement in fluent comprehension in the patient's top 3 day-to-day settings was 22%. Even though the 22% was a remarkable and reproducible improvement, we had a strong degree of confidence that even higher levels could be reached once the protocol had stabilized. The most significant results were obtained from treatment companion outcome reports. The majority verified a marked reduction in the patient's reliance on the ambiguity resolution recruitment as defined in the study and mentioned in Part 1 of this presentation. During this phase, only qualitative descriptions of the study were published on the hearcenter.org website and communicated to the public via surveys and seminars. The decision not to publish detailed findings was based on our knowledge about how the professional providers and the industry communicates with and provides its services to the public. Who are your patients? Independent studies confirm that when individuals purchase hearing aids for the first time and they fail to live up to perceived or real expectations, those individuals are highly likely to resist further efforts to improve their hearing for at least 8 more years. To us, those 8 years might as well represent a lifetime and would further lead to neurophysiological atrophy, making treatment even more complicated at some unknown future time. This was unacceptable to us. The hearing aid industry has perpetuated a long history of miscommunicating its capabilities to consumers in efforts to attract them to their particular brands of hearing aids. As a consequence, even the publication of interim findings could diminish the public's perceptions of the value of this treatment when it finally became available. Here is an example to illustrate this. In 1999, the National Council on the Aging published a study on the effects of untreated hearing loss on adults. The report established indirect links between untreated common hearing loss and psychosocial indications. Among other conclusions, it reported that long-term hearing loss can lead to social isolation and clinical depression. Since almost everyone with this condition waits several years before seeking help, the study could be construed by non-healthcare professionals to apply to all persons with hearing loss. Soon after it was published, hearing aid providers use this study as a motivational resource to increase hearing aid sales. They suggested that the purchase of hearing aids could stave off social isolation and clinical depression. While this may have been well-meaning and sincere, it perpetuated the notion that hearing aids alone could generate outcomes that we knew they could not possibly generate. So we delayed publishing results of our research and trial until we could determine how to ensure that patients' expectations could be met with objective reality-based outcomes. The main conclusions raised from this study were: number one, manually administered treatment would be time prohibitive in the private practice. Number two, for it to be properly administered, as many as 2 software-driven applications would be necessary to minimize time in clinic demands and reduce the potential for calculation errors. Number 3, an unknown level of training would be necessary to train physicians and non-physician practitioners to administer the protocol. And number 4, an advanced treatment would be widely accepted and adopted as a result of the primary care physician's understanding and administration or referral of the protocol to a qualified non-physician practitioner. Nobel Award recipient in the category of physiology or medicine in the year 2000, Dr. Eric R. Kandel, is quoted as saying that auditory functions unify cognitive skills, psychology, and behavior via genetics, molecular biology, and neurosciences. Dr. Kandel's contributions to neurophysiology and synaptogenesis are incorporated into Neurova doctrine. Since 2000, research in neurophysiology, memory, neuroglial interactions, cell signaling, and neuroscience in general has expanded intensely. It is almost impossible to keep up with the medical literature. Genetic expression is an exquisitely controlled activity-dependent process. Dr. Kandel's research led to at least 3 levels of complexity of new practical findings, beginning with the finding that extraordinary sensory activity under certain conditions can lead to genetic expression and synaptogenesis. Many of the mysteries associated with how that occurs have now been identified. Extraordinary stimuli is defined in terms of the rate, the spacing, the duration, and the sequencing of sensory stimuli. This provided us with raw material from which to begin to explore medically based protocol. The process his laboratory discovered is highly condensed on this slide. His laboratory subject organism was Aplysia californica, which has become a model neurobiological laboratory specimen. For those of you who are familiar with the study, you may also recognize many of the enzymes and other molecular participants in many other physiological functions. One of the most interesting results of his research is the distinctions that he draws between basal level of sensory stimuli and extraordinary levels. While it has been known for decades that sensory stimuli trigger the release of neurotransmitters, which in this case was serotonin, what was not known was how sensory stimuli triggers synaptogenesis and in locations remote from the nucleus. Dr. Kandel's lab proved that extraordinary sensory activity triggers not only higher concentrations of the release of the neurotransmitter, but also significantly higher concentrations of cAMP and calcium 2+. The levels of cyclic adenosine monophosphate and calcium 2+ reach a threshold, which triggers 2 additional reactions. cAMP protein-dependent kinase, or pKa, moves to the nucleus as a direct result of extraordinary sensory activity. Additionally, mitogen-activated protein kinase, or MAPK, in concert with pKa, moves to the nucleus. MAPK inhibits the regulatory cAMP response element binding protein, or CREB2, and pKa activates the catalytic transcription factor CREB1. What's exciting about this is that it provides us with a direct link and a potential application in hearing loss treatment. And as mRNA is transferred to the cytoplasm, it is activated by the only prion-like substance in the body to have beneficial properties. I'm referring to cytoplasmic polyadenylation element binding protein, or CPEB. These findings illustrate a cascade of highly structured responses to very specifically introduced sensory stimuli, which is central to the potential of Neurova to improve treatment for sensory neural hearing loss patients. As research emerges from around the world, discoveries of multimodal sensory interconnections provide even more opportunities to enhance the therapeutic potential, which may eventually allow even faster consolidation of rebuilt synapses into the auditory domain. Even at this stage in version 1 of Neurova, thousands of potential iterations of therapeutics and amplification protocols may be capable of further development to better serve your patients. What is exciting is that in this era of neurophysiological research, other findings of significance are emerging. Among them are the dynamics of the microglia, which are now understood to be fully capable of transforming from a dormant state into a macrophage when it detects unhealthy, underactive, or non-active synapses. It engulfs them as a protective measure and as though these categories of synapses are inimical to an otherwise healthy brain. This gives us a direct link between how diminished auditory stimuli can trigger even further degradation of the molecular circuitry, making it more and more difficult for patients to fluently comprehend, no matter how hard they try. From global research, what is now understood is that neurophysiological atrophy is a direct result of diminished sensory stimuli, and that other categories of glial cells also play a role in a bidirectional plastic capacity in the optimization of neural transmission. We'll touch on that subject next. Developing research emerging from Dr. Douglas Field's lab at the National Institutes of Health adds significantly to our understanding of consequences from extraordinary sensory stimuli as they trigger a cascade of plastic glial reactions. This research is important in two respects. One involves how sensory stimuli is capable of regulating numerous categories of plastic responses. The other regards the issue of tissue loss. We know that axons release ATP during neural transmission. What has come to light is that extraordinary sensory stimuli triggers a unique three-step reaction. Astrocytes sense the release of both ATP and adenosine. When ATP and adenosine are detected, astrocytes release a unique signaling molecule, the leukemia inhibitory factor. It is detected only by the oligodendrocyte. In turn, the oligodendrocyte engages in activity-dependent myelination. What causes this to occur is extremely high concentrations of ATP and adenosine, which are in direct response to increased levels of sensory stimuli. This suggests that every neuron's myelin levels and nodes of Ranvier are tailored to meet the transmission velocity demands as a result of higher levels of sensory stimuli. This is a potentiation. It confirms that the presence and degree of myelination is fully activity dependent and capable of upregulation. When one takes into consideration the fact that neurophysiological reactions are subject to multiple spectra of regulatory control, it appears very highly likely that myelination is also going to be subject to downregulation, which can now be assumed to occur as a result of the consequences of progressive hearing loss. This must be assumed at this stage in our understanding, because in terms of medical consequences, it could be harmful not to assume it, especially if something can be done about it. Here is a summary of what we know about this. Myelin is a major component of brain tissue. Myelin is plastic. Medical reports are emerging that link hearing loss to all-cause dementia and accelerated brain tissue loss. Tightly controlled mechanisms triggered by activity-dependent stimuli govern bidirectionality of plastic capabilities in the brain. The neurophysiological circuitry reacts to potentiation and depression by increasing and decreasing molecular circuitry accordingly. Plastic physiological circuitry is economically maintained and preserved by ordinary levels of sensory stimuli. Microglia may well serve a very important purpose to protect the brain from unintended action potentials, which could otherwise lead to seizures. They accomplish this by recognizing downgraded molecular participants and determining that when an atrophied synapse meets certain conditions, which are yet to be fully understood, microglia proceed to treat the potentially vulnerable synapse as harmful to brain health and to survival. So finally, what do we not know? The family physician may find tremendous practical value in answering this question. Could a cascade of deprivation-based physiological reactions to sensory neural hearing loss reach a stage when one or more thresholds are detected? And as a result, could they generate, accelerate, or otherwise lead to increased levels of brain tissue loss in every region of the brain which is responsible for associated neural domains that interconnect the primary language and ambiguity resolution schemas with other domains responsible for behavior, psychology, and higher cognitive functions which are a part of the neural domain as a whole. The Candle pathway and Dr. Field's research alone provides sufficient impetus for the medical profession to immediately recommend and administer medically based treatment for sensory neural hearing loss to 50 million people in the United States and just as quickly as we can reach them. One of the main goals of a medically based approach to auditory care is to recognize treatment mediators and act on them wherever possible. One of the most important physiological reactions that can be managed will be to utilize extraordinary stimuli via auditory verbal therapy under controlled conditions to generate long-term potentiation and synaptogenesis. If you have had experience with patients presenting cardiac arrhythmia, asthma, or diabetic hyperglycemia, then you will already be familiar with this enzyme. Of course, I'm referring to calcium calmodulin kinase 2, which is enriched in excitatory synapses in the CNS. This enzyme, which can be autophosphorylated, is critical to long-term potentiation. In the fluency recovery process, long-term potentiation is a highly desirable target. Again, extraordinary activity triggers high concentrations of calcium and high concentrations of glutamate in the delivering neuron. These concentrations can lead to the expulsion of magnesium, which blocks the N-methyldeaspartate receptor. It is the NMDAR which allows calcium 2+ into the postsynaptic density to trigger the formation of calcium calmodulin kinase 2. This complex, in turn, recruits ready NMDA receptors, which are transported to the postsynaptic density to deal with heightened activity. Normal and ordinary levels of stimulation fail to trigger this reaction. Low levels of stimulation are processed via the alpha-methylpropionic acid receptor, or AMPAR, which in terms of auditory cell signaling means that nothing more than replacement protein synthesis will occur. No retrograde signaling, no extraordinary vesicular trafficking, no genetic expression, no synaptogenesis. This is the expected and ordinary response to weak signals. Not only is the current amplification protocol representative of weak signals, but the inherent nature of the signals may be inconsistent with the intrinsic auditory patterns of sound to which the neurophysiological circuitry is already accustomed and prepared for. Here is yet another example which can confirm the need to apply medically based principles to sensory neural hearing loss treatment. We now know that sensory stimuli trigger a cascade of reactions which can be traced to calcium concentration in its essential roles in the phosphorylation of transcription factors and other activities which culminate in synaptogenesis. What is increasingly coming to light is the extended level of complexity of the steps involved necessary to trigger synaptogenesis. Here on this slide, we see several more binding proteins that are involved than were known when Dr. Kandel received his Nobel Award. They are also regulated by the entry of calcium 2+ through the N-methyl-deaspartate receptor, not just calcium calmodulin kinase 2. Here we see calcium calmodulin kinase 4 and others which are triggered by extraordinary sensory stimuli as Dr. Kandel defined it. 2 points to be made here. Calcium calmodulin kinase 4 mediates the activation of the CREB binding protein, or CBP. It, in turn, is recruited to promoters not only by CREB, but by other DNA binding proteins. What this means is that the process uncovered by Dr. Kandel led to the discovery of numerous levels of complexity regarding equally activity-dependent participants in the process leading to synaptogenesis. The only method that will allow sensory neural hearing loss to be most effectively treated will be that particular method which links its professional steps and objectives to physiological certainties or probabilities, which is the norm for medical procedures. Even other genes, such as immediate early genes and secondary response genes, are representative of the sensitivity of the stimuli or the sensitivity to the stimuli, which either function or not as a result of the intrinsic properties of auditory patterns. Another binding protein, methyl-CpG binding protein 2, is phosphorylated by calcium calmodulin kinase 2. Our targeting of this enzyme could lead to the regulation of other genes involved in synaptogenesis, which research has yet to discover, but which we can confidently assume will be recruited due to the objective applications of amplification as defined in medically based treatment. Now that we have begun to describe the rationale behind taking an objective and medically consistent approach to treating your patients, let's examine how cognitive load principles can affect patient-reported outcomes as a result of hearing aid use. In guiding the sensory neural hearing loss patient to the fullest recovery of fluent comprehension, the auditory care professional must incorporate auditory verbal therapeutics and progressive amplification steps which are fully consistent with educational cognitive load principles. Cognitive load is comprised of 3 categories. The intrinsic cognitive load represents the inherent difficulty of information being processed in the brain. The vast majority of cognitive psychologists and educators agree that it is a challenge to develop methodologies which are consistent with an inviolable principle of the intrinsic cognitive load, which I will describe to you momentarily. The germane cognitive load is determined by educational outcome experiences and research to be the most effective multimodal methods available to educate a learner. Components of the germane cognitive load are primarily visual and auditory. The extraneous cognitive load is determined by educational outcome experiences and research to be the least effective methods utilized to educate a learner. A popular example of this involves teaching an individual the difference between a rectangle and a square. Using formulas and describing the distinctions between the two represent the least effective method. The aha moment for the student is most likely to be experienced when the teacher shows the student a picture of a square on one side of the table and a picture of the rectangle on the other, and then simply explains that a rectangle either has 2 shorter sides or 2 longer sides. The cardinal rule of education with respect to how professors introduce the intrinsic cognitive load of material to be learned is that the inherent difficulty of the subject matter absolutely cannot be altered. If concepts and inherent degrees of difficulty are altered, the attainment of expertise becomes exponentially more difficult than the inherent difficulty itself, and as a consequence, expertise may become unattainable. One example that all of us share is that attempting to learn the Krebs cycle or the electron transport chain would have been impossible without first having had math, chemistry, organic chemistry, anatomy, and biochemistry, and in that particular order. Can you imagine taking a cell signaling course without having fulfilled those course prerequisites? And can you imagine the neurophysiological correlates in your molecular circuitry if you attempted to approach a medical education that way? Cognitive load issues are critical for three reasons. Number one, the educational process that culminated in fluent comprehension, from explicit memory and implicit memory to language schemas, ambiguity resolution schemas, and everything in between, are transduced multiple times and eventually programmed into a dynamic, organic, neurophysiological-based circuitry, which we are only beginning to understand. Number two, auditory stimuli present a wide range of inherent difficulties to the cognitive load, from missing signals to corrupted stimuli, and from variations in the production of speech to impacts in a number of other areas. And number three, routine amplification rationales within hearing aids have been predicated upon theories that significantly alter the intrinsic cognitive load in order to make listening more comfortable and to make speech discrimination easier. The original modern hearing amplification formulas circa 1944 to 1976 were extremely limited by electronic technology. The theoretical principles upon which hearing aid functions were structured made it impossible even to consider accuracy or precision in either volume or frequency. In addition, little was known in the correlation of neurophysiology to hearing aid functions or hearing functions at that time. As a result, any professional methods that improved audibility and made listening comfortable were considered valid, acceptable, honorable, and desirable. Unfortunately, that mentality and theoretical rationale persisted to the degree that even after advances in hearing instruments and an explosion of research in neurophysiology, current amplification models continue to effectively alter every level of cognitive load as identified by those theoretical principles. As explained in the previous slide, three major conflicts may make it impossible for digital signal processing to handshake with the neurophysiological programming that has occurred in the brain and sustained natural language skill capabilities for the majority of the individual's life. So improved audibility under the current model comes at the cost of the recovery of fluent comprehension skills. This is exactly what medically based treatment is designed to overcome. Now we can turn our attention to medically based treatment, which we call Neurova. Tailored case management begins with a diagnostic audiometric battery and a detailed patient history, which allows the auditory care professional to identify patient-specific treatment factors and the family physician to identify medical mediators, both of which will carry relative weights in the determination of the overall progressive amplification stages, which are directly linked to the progressive therapeutic auditory retraining. The target is a medically based recovery of natural language skills and the regeneration of as many neurophysiological interconnections or synapses as can be regenerated. The treatment factors listed on this slide are further divided into several relevance-weighted subcategories. The subdivisions are identified from patient history data, questionnaires, and evaluations. They are then entered into a dynamic software technology which can instantly develop the ideal treatment plan for the patient. and recalculate an amended treatment plan as necessary to adjust progressive amplification stages and therapeutic regimens as conditions warrant. The main components that are missing are medical mediators, which you can easily provide to further improve your patient's health and recovery. As we've pointed out, the typical correction leads to predictive amplification based on the audiogram. In medically based treatment, at this point, we have identified over 200,000 possible patient-specific treatment plan combinations. As a result, it would be practically impossible for a private practice to manually calculate a clinical treatment plan and administer it. The black dotted line represents an approximation of a predictive hearing aid output profile based on the hearing loss, which is illustrated by the green solid line. Using a medically based protocol, the number of intermediate amplification levels is determined by the cofactored relative weights of the patient's treatment factors. Therapeutic content at each intermediate amplification level is based on the same treatment factors. Auditory retraining therapeutic sessions are self-administered in the non-rehabilitative settings most comfortable for the patient. Ambient levels in the NRS are measured by patient or companion prior to each session with a digital sound meter. Results of each therapy session are recorded and stored for the benefit of both the patient and the auditory care professional. A certified auditory care professional can extend sessions and treatment trajectory based on recovery levels, changes in the patient's status, and compliance conflicts. The primary stage of synaptic restoration and recovery is estimated at 12 weeks. Timing of therapeutic samples, sequencing, phonemic content, and degrees of phonemic difficulty are tightly structured during this stage. Variations during this stage are strongly discouraged. In clinical applications, tailored therapeutic content is determined upon login to the server before each session begins. The therapeutics are conducted nightly without professional supervision for a period of approximately 2 weeks at a time. At the end of each interim session, the patient returns to the clinic for advice, counseling, and an additional amplification adjustment. Auditory care professionals schedule up to 15 minutes for this procedure. The process is repeated until the final amplification levels are reached, binaural symmetry is recovered when possible, and the recovery of language skills has reached optimal levels. 26 levels of tailored, customizable fluency rebuilding and language reorientation therapeutics leads the patient to recovery as long as intermediate follow-up adjustments are met in the clinic. Due to variations in lifestyles, the patient may choose to discontinue therapeutic sessions upon reaching a level of recovery which matches the patient's lifestyle demands. Advanced features are not activated during or after medically based therapeutics. However, due to potential changes in the future of the patient's cognitive status, the certified professional can activate such features upon the recommendation of the family physician. Narova is highly recommended for patients who present simultaneous signs of both sensory neural hearing loss and early-stage cognitive decline. In general, once therapeutic sessions have been completed, a patient's less active lifestyle could warrant more relaxed sessions to ensure the preservation of fluency recovered during therapy, which otherwise would not be likely to be maintained due to less active social interactions. To recap, we identify the treatment factors. We integrate treatment factors and amplification protocol into an ideal treatment plan. We identify the patient's personalized therapeutic content needs in phonemic categories and calculate the frequency, sequencing, and spacing of auditory therapeutic repetition sessions. These therapeutic stages are linked to objective levels of progressive amplification so the auditory care professional is acutely aware as to whether the primary language schemas and ambiguity resolution schema reorientation is occurring in a natural fashion. If not, this knowledge allows the auditory care professional to adjust the therapeutic regimens as necessary to extend the therapeutic process with additional counseling. This is why we have taken the liberty to characterize medically based treatment for sensory neural hearing loss as a long overdue and critically needed shift in the paradigm. Now let's turn our attention to the consultative medical collaboration that presents opportunities for you and your patients. Your contributions, expertise, and dedication to the well-being of your patients are necessary to the long-term development of medically based treatment for sensory neural hearing loss. We invite you to join us in the maturation of this paradigm. 17 to 20% of your adult patient panel is eligible for this clinical treatment. 91% of your patient panel who already use hearing aids are also eligible for a preclinical treatment regimen. A list of all currently known main exemptions is available directly from us or through your dispensing audiologist. Just to give you an idea of the categories of exemptions, moderate to severe Alzheimer's disease, moderate to severe all-cause dementia, advanced Lewy body dementia, and sudden sensory neural hearing loss are examples. You are invited to participate in a protocol developer consultancy agreement. You will be compensated for participating in at least 2 pharmacological questionnaires per referred patient over a period of 4 to 9 months. Additionally, you may be invited to respond to a series of patient-specific treatment step and related protocol questionnaires as they are developed over the same time period. If any of your patients happen to be treated for conditions which will be identified during this long-term study, you may be asked to participate on entirely different levels that have been described here. The treatment mediator study is just one of the several ways you can elect to raise standards, improve levels of care for your patients, and increase your practice's revenue. The feasibility of these options may be partly determined by identifying current procedural codes accessible to you, but which may not be routinely subject to split share or accessible at all to the dispensing audiologist. That is, unless the relationship between you and the audiologist is a direct relationship. Examination, patient history, cognitive screening, auditory rehabilitative counseling, and numerous related procedures may provide additional compensation for Neurova activities to your practice. Procedural code links are listed on slide 40. In addition to selected reimbursable services, the current minimum compensation to the physician is $150 for each pharmacological treatment mediator questionnaire that is completed per patient referred to an audiologist who's been certified by us. The minimum necessary to fulfill other mediator or treatment factor studies will qualify for similar levels of compensation. The maximum compensation will be based on the following 2 factors. Number 1 is the determination by your reimbursement specialist. Number 2 is the extent to which your practice administers any of the case management objectives that you decide you want to administer or should administer in accordance with Neurova's protocol. This level of compensation could increase your per patient revenue to the practice by up to $1,000, depending on the division of responsibilities between the physician and the non-physician practitioner. Your participation will be welcome in any treatment mediator study category. In addition to the pharmacological mediators, several other treatment factor and related research projects are being considered. If you are interested, you will certainly be informed of the extent of your participation opportunities. Just from what you know so far, it's obvious that we have opened the door not only to a new era of treatment, but also a new era of responsibility. Neurova's optimal value certainly doesn't depend on any make or model of hearing aids, as long as they're high quality. It now depends on many other routine and accepted healthcare factors. Here are a few representative examples of the medications that will be necessary for us to consider as we continue to refine how we tailor the rigor and length of the therapeutic sessions. This knowledge will also play a role in how we communicate each patient's expectations of recovery levels. Who would have ever imagined that, for example, treatment for GERD could have an impact on hearing loss? But it could, and it could in numerous respects. Just the possible impact that proton pump inhibitors can have on serum magnesium is a consideration that must be explored. Online questions will be available for completion before and after your patients receive the treatment. As you could guess, acetylcholinesterase inhibitors such as rivastigmine, glutamate modulators such as memantine, calcium channel blockers, CAMK2 inhibitors or antagonists, including any medication in the phenothiazine class, and then typical antipsychotics that provide any level of chlorpromazine equivalence. All of these are included. All of these must be explored. You will also be asked to notify the auditory healthcare provider of any substantive changes in status of your patients as they occur. As the developer of the medically based treatment model known as Neurova, we affirm that we are not affiliated with any hearing instrument device or manufacturer. The treatment model can be administered through any certified healthcare professional without regard to make, model, or style of hearing instrument. Any high-quality digital hearing aid is capable of providing therapeutic amplification levels for the purposes of Neurova. As the developer, Neurova does not derive any revenue from any federal healthcare program. Our compensation guidelines fall well within current fair market value guidelines for routine consultative services. We hereby declare a competing interest. Thank you for being with us today. Please contact your Neurova certified practicing audiologist for details. Or if you're not associated with the dispensing audiologist, please contact us directly at the email address on this slide. We look forward to working with you in the future. You're welcome to take advantage of the contents of the next 7 slides, which provide you with citations, references, and links to subjects covered in this presentation. We wish your patients well on their journey to better hearing, healing, and more effective natural comprehension of their language.